Hello, everybody. Welcome to this interesting session about 0.0.1 lesions. It's a challenge. It's for me a pleasure to share the session with my colleague and my friend James. And in the panel, Stéphane Nobel, Niccolò Ciardetti, Dougal McClean, Gregory Pavlides, Pavlides, Saurabh Mehrotra, and Christos Zambakides. So we can start with Javier. Javier. The first presentation is treatment of left main bifurcation lesion 0.0.1 with an stent across plus spot.
Thank you for the invitation. It's a pleasure to be here. 0.0.1 lesions really remains challenging, but somehow this is paradoxical because if we take a look to this ranking of bifurcations according to Medina classification proposed in this document of definition and standardized endpoints for the treatment of bifurcation, 0.0.1 lesions were the lowest in severity. Meanwhile, in this large registry, in this large registry, analyzing the impact of Medina classification, the 0.0.1 lesions were associated with a higher incidence of target lesion failure. And probably this is because there is a lack of standardization to approve these lesions. And in the setting of the left main, the ostial circumflex lesions represents a particular challenge due to its complexity, and there are several key points we have to take into account when we are selecting the strategy, like the calcium burden, angulation, the size of the left circumflex, and the plaque extension that when we analyze by intracoronary image used to be diffuse rather than focal. And we have two main strategies, PCI strategies, to approach these lesions. The inverted provisional strategy with the stent across or the nailing the ostium. And recently, DCB has emerged as an alternative in this scenario, but its role has yet to be established. But there is a lack of randomized trials or large registries to shed light on what the ideal strategy should be. We have to know the pros and cons. With the stent across, we provide the total coverage of the ostium. We can do an aggressive post-dilation as we are protected by the stent. And on the other hand, as a drawback, we are stenting part of the bifurcation that is free of disease. And the great angulation of this bifurcation can increase the stress platform, and this could have an impact on MACE at follow-up. And regarding the precise stent, it's an alternative in ideal 90 degrees angulation, but in acute angulation we are going to have geographic miss or excessive struts protruding into the left main, and this may damage ostial LED and may be difficult to access in further procedures. So from April 2017 to October 24, we have performed 584 PCI left main, and 0.0.1 lesions represents 6% of all the left main bifurcations, and most of them have been treated with stent across, and this is the cohort that we are going to analyze. Here we have the clinical data. Most of the patients were male, mean age 71 years, with hypertension, hypercholesterolemia. More than 1/3 of the patients were diabetic. And regarding angiographic data, it's remarkable that we treated large circumflex with left dominance or codominance in almost 50% of the cases. Most of the lesions had angiographic calcification, high percentage of intracoronary image, mainly IVUS. We predilated 86% of the lesions in consonance with the angiographic calcification, more than 90% of POT, and 48% of kissing balloon. In 3 cases, we needed to prepare the lesion with rotablation or laser, and only 1 patient needed a second stent. And I'm going to illustrate our experience with 3 different cases. This is the first one, a tight lesion in the ostium of the circumflex with heavy calcification, We started with rotablation with 1.5 millimeter bar, and we have the angio here and the OCT that confirms the presence of nodular calcification with some fractures induced by the rotablation. So we then did an aggressive predilation with an OPA balloon at 13 atmospheres. We filmed the balloon inflated with a stent boost to correctly assess the expansion of the balloon before stenting. Then the stenting was selected according to the reference of the left circumflex, pot with 4.5 millimeters balloon, and kissing balloon with non-compliant balloon with diameters according to the reference of LAD and left circumflex. And we can see the impact of post-dilation stent geometry after pot and after kissing with the stent boost. Good angiographic result in both orthogonal views, but the OCT revealed the presence of a proximal LAD dissection in more than 5 photograms. This was not evident by angio, but we decided to fix this dissection with a second stent, with a tap technique, using the stent boost to correct precisely the stent with minimal protrusion into the left vein. And after the stent, we finished the procedure with a final kissing balloon, and good angiographic result in both orthogonal projection, and we did a final pullback from the left circumflex, and here we can observe a fantastic adaptation of the stent to all the segments of the bifurcation with the scaffolding of the ostium of the LAD, as we observe in the bench test when we cross through the distal cell, and good expansion in terms of area, the ostium of the CIRC with 7 square millimeters, and good apposition and expansion also in the left main. And the pullback from the LAD that shows the protrusion minimally, the stent into the ostium of the circumflex, and good expansion at the ostium of the LAD with 7.7 square millimeters. The second case is a patient with previous chronic total occlusion of right coronary artery and acute coronary syndrome with non-STEMI as a clinical presentation, and a severe lesion at the ostium of the circumflex. The IVUS exhibit fibrocalcified plaque without positive remodeling and with a large left main free of disease. And we treated with an inverted strategy, pre-dilation with cutting and non-compliant balloon, a stent, and pot with a 5 millimeters balloon that was selected according to the information of IVUS. And this is the angiographic result. Excellent in the stented segment, and the IVUS pulled back from the left circumflex that exhibit good expansion at the ostium of the circumflex, 7.8 square millimeters, and a circular expansion and apposition of the stent in the left main. This is an excellent example of how contemporary stents are able to adapt to the different segments of the bifurcation despite the different diameter reference. We also assess the final result by IVUS, the LAD, excellent situation of the ostium of the LAD, 10 square millimeters at the level of the bifurcation. We can see that we do not see a stretch facing the ostium of the LAD. Probably the cell that is facing the ostium of the LAD after pot with 5 millimeter balloon is so large that the degree of jailing is low. And with this result, we didn't do a final kissing balloon. We think that this situation is totally safe. And this final example is the 0.0.1 by angio that we analyzed with IVUS from both branches. And the severe plaque of the ostial, it was extended to the left main and to the ostium of the LAD. Good luminal area at the LAD, 5.2 square millimeters. And in the left main, we had a gray zone in terms of area between 4 and 6 square millimeters. We also did the physiological assessment with co-registration in both branches, and all the physiological impact was related to the ostium of the circumflex, and the pullback of the co-registration from the LAD, it didn't have any impact. So with this information, we again opt for an inverted provisional strategy, pre-dilation stent pumped with 4.5 millimeter balloon, and this is the final angio. Excellent result in the stented segment and a mild stenosis in the ostium of the lady. We assessed with physiology with an IFR of 0.87. So we finished the procedure with a kissing balloon, with the diameters adjust to the reference of the LAD and circumflex. And here we have the final angiographic result with normalization of the IFR, of the physiological index, and good areas in terms of expansion. We have 11.5 square millimeters in the left main, in the ostium of the LAD 6 square millimeter in a non-stented segment, and in the ostium of the left circumflex 6.7 square millimeters. After a mean follow-up of 3 years, we have 20% of MACE, 2 cardiac deaths in patients, both with previous ventricular dysfunction and heart failure, 1 myocardial infarction, and 4 target-late revascularization. 3 out of 4 TLR were in the first year, and the 4th case was at the month 22. And one of the patients with restenosis had as a clinical presentation myocardial infarction, that is the infarction that is marked in the table. So, in conclusion, stent across and pod in left main 0.0.1 lesion is a feasible technique with low TLR at long-term follow-up. Intracoronary image should be mandatory in this scenario because it provides information about plaque composition, reference diameters, selecting then an accurate stent, and about stent expansion and apposition. And large registries and randomized trials are needed to standardize the approach to these complex lesions. Thank you very much for your attention.
Thank you very much, Javier, for starting the session with this excellent view on how do we actually treat the ostium in the side branch. And just to set that into a broader perspective, one of the main issues at discussion for the club this year is actually how to manage the ostial circ. And we have heard from the discussions yesterday and a lot of other discussions in other meetings that where we really see long-term follow-up problems, it is in the roof of the circumflex in the left main, and it's in the roof of the side branch in general non-left main bifurcations. So there's something about the technique we are using, there's something about the perception, the geometry of the lesions that actually made that roof of the side branch vulnerable for late events. You had your registry here, and it was obviously that you like the crossover stenting, although there was some of the others. So I would like to just shortly to comment on what is the, one of the caveats of the crossover stenting is actually that you treat a normal vessel to treat a ostial side branch lesion. And that is actually both the dilemma and the complexity. So what are your more philosophical takeoff of that part?
Yeah, that's the drawback, but we have to think in the alternative. The alternative is to nail the ostium. It's a very complex, because the circumflex ostium has a lot of elastic fiber content, there is a lot of recoil, and probably you need an aggressive preparation and predilation. If your strategy is going to be precise or nail the ostium, if you are aggressive, probably there are collateral damage in the left main. So if you, nowadays with post-dilation techniques, with intracoronary image, with the techniques for modification plaque, we are able to properly prepare, and I think that although we are stenting healthy left main, angiographic healthy left main, with the technique guided by intracoronary image is a thing that we can assume.
Yeah. Yes, totally agree. Yeah, can we have, yeah, yes.
I guess this is not working. Yeah, so that was an excellent presentation. I have two questions. One is that most of the cases that you showed, had an isolated ostial LCX disease. You know, the disease was not really diffuse. So when you're jailing the LED, which is the main vessel of the body, don't you think it's imperative that you do an FFR because it was a focal lesion in most of the cases? And you never know, the FFR might come out to be negative because it wasn't a diffuse disease and the patient can be left on medical therapy thereafter. That's my first question. Second is that you did a kissing in almost half the cases and you had a 7-year follow-up. So was there a difference in long-term outcomes in patients who were stented from left main to LCX who had a kissing versus patients who did not have a kissing?
So first question is about physiology?
The first question was that since most of the cases that you showed had an isolated ostial LCX disease, do you think it would be important to do an FFR prior to intervention because you're jailing the LED?
Yeah.
How many cases had a fractional flow reserve done prior to intervention?
Our practice in this, we assess and we find an ostial circumflex, and we are going to to treat with a stent across to evaluate the impact on LAD after kissing, carina displacement, or that we do image always, and many times we leave the pressure wire in the LAD, which is trapped by the stent, and we assess with that wire. And then we remove, we see that there is no drift, and depending on the result, we decide whether to do kissing or not. When we post-dilate, we manipulate in certain the geometry of the platform, and there is, for me, there is the best manipulation of the stent is not to manipulate. That's why many times we pre-dilate in true bifurcation, stent and pot, and we do not manipulate. When we do post-dilation maneuvers, there is a possibility of altering the geometry of the stent. So, to do kissing or not depends on the result of the ostial LAD, and that's the main decision we take.
So a stepwise approach, actually, not a preformed delivering of the stent in a preformed manner, but a stepwise, see how it develops and then make new decisions on top of it. Well, we will have tons of chances to discuss the technical issues. So thank you very much for the first part here, and let's move on with Francesco Tartaglia to talk about the DCB in treating the left main, please.
Dear Chairman, thank you for the kind invitation to present to the EBC 2025 Congress. The title of my presentation is Treatment of Left Main 0.0.1 Bifurcations with DCB, evidence from the DCB-CIRCO registry, which I had the pleasure to coordinate together with Sandeep Basaravajaya and on behalf of Professor Antonio Colombo. So the topic of today is how do we treat this kind of lesion? We know from previous evidence and from the other presentations of today that treating ostial left circumflex with a DES can be technically challenging, and it is associated with a high rate of restenosis. Leaving it untreated is also associated with a double risk of adverse events in a recent study. Hence, we could think about using a DCB. The Gregory balloons have been used in bifurcation in the recent DCB BIF trial, showing promising data, although no data on ostial left circumflex were available. In bifurcation, DCB can be used as part of a planned hybrid strategy with a DES in the main vessel and a DCB on the side branch, or in isolated Medina 0.0.1 lesions, a DCB can be used on the side branch alone. How do we use them in bifurcation? It's similar to what we do in other coronary segments. So the focus is on lesion preparation. We could use non-compliant balloons and specialty balloons. After the lesion preparation, we should check for any complication, and if the lesion preparation is adequate, both with angiography and with intravascular imaging. If it is not adequate, we could use higher pressures, longer inflation time, and other specialty balloons, or trying to rotate the specialty balloons we already used. When we are satisfied with lesion preparation, we can deploy the DCB a little bit longer than the actual lesion to prevent geographic miss. We don't need high atmosphere, we just need to deploy the drug, deploy it within 2 minutes, and it is not a problem to protrude towards the left main, as the DCB diameter will be lower than the left main diameter. So this is our study that was recently published in CCI. Our aim was to compare DCB and DES in the treatment of ostial left circumflex lesions. This was an observational, retrospective, multi-center, investigator-initiated registry conducted at 8 international centers. The consecutive patients undergoing DCB on ostial left circumflex were enrolled from 2018 to 2023 in the DCB arm, and we included both Medina 0.0.1 lesion, then other lesions of distal left main bifurcation with disease on ostial left circumflex. In the DES group, we included an already published cohort of patients who underwent PCI with DES for ostial left circumflex lesion at 3 Italian centers from 2012 to 2021. We perform a one-to-one propensity score matching using both clinical and angiographic covariates, and our primary endpoint was target lesion failure as a composite of clinically driven target lesion revascularization, cardiac death, or target vessel MI. The key secondary endpoint was target vessel failure, and here you can see the centers that were included. We included 152 patients in the DCB group and 351 in the DES group. Most of patients were male, their age was about 70 years, a third was diabetic, and around 2/3 presented with chronic coronary syndrome. All the clinical characteristics were well accounted for by the propensity score matching, which left us with 126 patients for each group. We found that in the DCB group, fluoroscopy time and the total amount of contrast used were lower, and this was confirmed even after propensity score matching. Multivessel disease were more frequent in the DES group, while lesions were a bit longer in the DCB group. Median lesion size was 3 millimeters in both groups. The 0.0.1 lesions accounted for around 40–45% of the total lesions, and IVL and cutting or scoring balloon were more used in the DCB group both before and after propensity score matching. As for the treatment strategy of the bifurcation, in the DCB group, an hybrid strategy was used in 27% of cases, so a DES on left main LAD and a DCB on left circumflex, while in the DES group, a dual stent approach was used in around half of the cases. For a primary endpoint, we found an incidence rate of 19.8% in the DES group and 19% in the DCB group, with no statistically significant difference, both before and after the propensity score matching. For the secondary endpoint, target vessel failure, we found an incidence rate of 28.8% in the DES group and 21.5% in the DCB group, so numerically lower, but again, not statistically different, both before and after the propensity score matching. We performed several subgroup analyses, but for the topic of today, we have seen that in the Medina 0.0.1 group, there was no different result as compared to the other Medina kind of lesions. And this was confirmed both in the whole cohort of patients, so DCB and DES, and also only in the DCB cohort. Our study has several limitations. Clearly, its observational design, the different enrollment period in the two groups, although we saw that TLF rates remain stable over time in the DES cohort. The follow-up was quite short, only 2 years, so it might be too short to unmask late adverse event associated with both the kind of treatments, and only high-volume DCB-PCI were included. However, I want to stress how in the DCB group, both the fluoroscopy time and the amount of contrast used were lower. So DCB-PCI can have the benefit of reducing complexity of PCI, or making complex PCI less complex. And we have previously shown that in another work where we saw that in de novo complex PCI patients had similar TLF rates as compared to no complex PCI patients. And lastly, I want to show you this paper from the group of Professor Shin when they demonstrated a benefit of the use of DCB on the ostium of side branch in terms of MLD and diameter stenosis. And this is pure speculation, but we may think that using a DCB on ostial left circumflex may positively affect also the ostial LAD, even in case of subcritical lesions, although this remains speculation. So to conclude, our study was the first dedicated study evaluating DES versus DCB for ostial left circumflex lesions. The use of DCB was safe and showed comparable outcomes as compared to PCI with DES. I want to stress that DCB may help simplify and shorten the procedure in these cases where placing a desk can be challenging, and although this is not randomized evidence, these data support the use of DCB in this complex setting. Thank you for your kind attention.
So I think that the presentation is pre-recorded, so we have not the presenter among us. Any comment from the panel?
Well, I think my only concern while using a drug-coated balloon from left main to LCX is how do you actually size it? Because let us suppose the proximal LCX or the mid LCX is 3.5 and the ostial circ would be 4 and the left main would be 4.55. So how effective would, and our main target is the ostial circ where you have the tightest and the most fibrotic lesion. So you size the drug-coated balloon to the mid to the distal landing zone, which would be 3.5, let us suppose hypothetically. Then how effective would be our drug-coated balloon in the ostial portion where we actually wanted to act, where the media to media would be 4 or 4.25?
Well, this is actually one of the discussions that we will have, which of course is critical. But if it's just an ostial lesion, it doesn't matter if you touch the wall in the main stem, if it's just the ostial lesion. But if you both want to treat the circumflex and the ostial left main, then it's another problem. Yeah.
My comment will be actually in following with the previous one, is not so much the technical part, is what are the criteria of a successful DCB? Because we don't know, I mean, what is the accepted residual stenosis that is left behind? Did they use any imaging? Did they, when they're concerned if there were any, say, small dissections? I mean, these are all important things. Since we have all the data for using IVUS for stents, but we don't really have a lot of data for doing simple angioplasty, and DCB is simple angioplasty. So I think we probably should elaborate on the criteria of a successful DCB at the end, which other than the drag on the balloon might be very important too.
Yeah, and I think also that imaging is key. But the problem is also that in DCB, we don't know, we have no data on imaging use, so we can use imaging to understand if the Medina, to also reclassify the Medina, because of course if you do imaging in the main vessel in the LAD, maybe you understand that it is not only 0.1 Medina, but maybe there is also, this is in the ostial LAD. And so you have to treat also the ostial LAD, but of course we have to know also what to see with imaging after DCB treatment.
Yeah, it's a very valid point, because to get a good result to the DCB, you actually need to get a good pre-dilatation, and actually it's preferred that you use a scoring balloon or a cutting balloon, so you're going to have X amount or a little bit of dissection, and exactly that. You need a bit of disruption for the drug to actually get where it's supposed to work. So I think it's a big learning curve that we're going to need to go on with DCBs.
Image, I think, is an important point, but in general, it's not used in many procedures when you use DCB. In our study, it's not mandatory. In the EBC DCB, image is not mandatory. And probably if you do image, probably the rate of crossing will be high. So you have to accept and worse immediate result with a stent. The study is interesting, but we wait for the next randomized trial that is prepared by Francesco Bulsota. This is a randomized trial, DCB versus stenting in 0.0.1 left main bifurcation lesion, and probably that will provide valuable information in this topic.
Well, let's wait a little bit with the more questions, because we will move over the program, and we would like to invite Professor Nakamura to come and give him talks. We are so happy to have you here. So please enlighten us.
Okay, thank you very much. Just enjoy my talk. My talk is nailing the circus solution. This is Shibai. Actually, I'm a very experienced PCI operator, including 10,000 seat of PCI and so on, so on, so on. But the most important one is I don't want to implant a stent in a circumference solution, actually. Reason. We have a method registry, 20 years, having a more than 2,000 reference PCI, more than 40 papers with Antonio and Araide. About the circumference, this is my presentation title in the EBC 2016, 10 years ago, actually. At that time, I showed the circumference independently, circumference solution itself independently showed high response rate in patients with reference PCI. And among the responses of reference PCI, responses of circumference solution is not directly linked to the fatal prognosis in most of the cases, so should be focused on the respect to LD. And this phenomenon is the same as the second generation DS. Two-stent strategy might have been caused by the high development of circumference restenosis. However, overall, this has a little impact on the long-term mortality. And the number 4, actually, this is an implant in the BVS. You already forget about this. Just 6 months later, actually implanting the circumference solution, just in 6 months later, patient coming back to the recurrence of the symptom, and you can see the OCT collapse the circumference solution area of the BVS. So I said at that time, do not chase too much circumference a different animal. This is very unique part of the coronarity, so-called the hinge point, and point is the moving and twitching. Not so much important as compared to the LD-LCA for keeping ejection fraction of the patient heart. Actually, this is a CT image from my hospital. Watch movement of circus is proximal with cardiac cycle. Another case, you can see the movement of circumference. This, interestingly, if we have a very calcified left main bifurcation area, no movement. So at that time, I said that we are always watching Mr. Circumference. You are always tough. We're better to let it go. Actually, about the angle, bifurcation angle, if you compare the high angle and the small angle, large angle is associated with the circumference responses even a left main to the LAD. Then left main large angle, bifurcation angle is a predictor of the TLF. So if you step in the circumference solution and the nailing, for me, I never failed mess up. I never failed in. I never come back easy. So technique, nailing the ostium. We have a stent pullback technique and a nano-crushing technique and the inverted progener T-stenting techniques, maybe only for the maybe 001. The shoulder technique and the modified floor petal technique. Actually, this is a little bit interesting. Balloon, bit back and the ballooning, and then the wire goes through the stent slot, and then advance the balloon, and located in the bifurcation area, and then the ballooning side branch, stenting, and the ballooning main branch, and the ballooning again. You can see the protrude final proximal strut coming to the like a anchor, something like this. This is very beautiful. Clinical result. Actually, clinical result of PCI for 001 is not so good. Actually, this is a paper from the Mamas, and from Jaha. Actually, they show the clinical result of the 001 is worse. TLF, cardiac death, TL is worse. Actually, he said. And this is very great, the Asian registry, the Korean registry, Kobe's registry, They show the comparison of clinical outcome according to Medina classification, 0.0.1 is worse. Even one stent or two stent. And this is a paper from Dr. Murasato, EBC friend. And this is the distribution of the Medina classification in spite of the very low distribution, the 0.0.1, but actually MACE, TLF, worse clinical outcome. So clinical result procedure outcome, the PCI was no involving a circus artery. This is Antonio Colombo's paper. Actually, very worse outcome. And if you look at the multiplicity analysis of predictor or event, and even actually, if you use the imaging, this is negative predictor of the MACE. But comparing very ostial or two-stent strategy, actually any stent strategy have no major impact of the event rate. Stent strategy have no major impact of the event field. And this is a Javier's paper, propensity match analysis of long-term clinical result of the ostium, the Saurabh comparing the LED ostium. Actually, they pick up the more than 600 patients, and actually, after the propensity matching, ostial Saurabh 47, ostial LED 47, and comparing the Saurabh ostium show the very worst outcome. This is the predictor of the TLF. Ostial Saurabh PCI is worse. I told you 10 years ago. Okay. So isolated ostial Saurabh have an increased risk of TLF in comparison with ostial LED. Of course, nailing the stent, the Saurabh ostium is not so good. So to get the better clinical outcome, need maybe best preparation for achieving a good stent apposition, stent slot apposition, avoiding overlapping, avoiding a complication. So fast imaging important. Actually, if you can identify the target, everything is going to be different. Different opponents should be deal with a different tool. I'd like to introduce a 3 effective tools for the 0.0.1, DCA, Diamondback, and Shockwave. First DCA, actually this is only for the available in Japan. But actually comparing maybe 20 years ago, this is a very nice one. Very sharp cutter, maybe double. The smaller catheter, 7-French compatible, and very flexible, and the high amplitude, the 2 times stronger. Okay, this is a case of a left-hand bifurcation lesion, 2 bifurcation lesion, 2 bifurcation lesion, 2 bifurcation lesion. If you look at the IVUS, actually, you can see the large plaque burden, no obvious calcium. In this kind of case, using DCA, this is just a test cut. And then to confirm what we have done right or not, just a direction, and then a further cutting. Need to check how much plaque burden already removed and still safe or not. Actually, a little bit of time consuming, but maybe I think around the 30 minutes we can finish. And plaque burden going to less than 30%. And circumference DCB. And the straight part, stent. And then no overlapping stent. Oh, nice. Next culture lesion. Actually, each devices have each mode of action, each power of action, each feature, and ease of control, arbitrarity to change direction. I'd like to insert Diamondback and the Shockwave, good target, weak target, risk of complication. First, Diamondback. If the the plaque located around here, move back and forth. This is Diamondback. And if you want to develop more, maybe just press on the high speed. This is a case of a circus ostium area. Move forward, move backward. And then if you get a good vessel preparation, the stent easily. Shockwave, low amplitude, high frequency waveform, the good dedicated balance system, just crack the Shockwave. This is very particular case of the very severe calcium lesion from the ostium of the Saurabh. You can see the calcium nodule and the Shockwave, 2 Shockwave, and then a stenting. you can see diffusely severely cultured circumference can open very fully. Pre and post. This is actually amazing. So image of the diamond back on the rotor and the shockwave is something like this, like a hard attack and just touching and pushing the timing. This is a different shockwave. Promising feature of the DCB, actually previously already reported about this paper, okay? And they show they are not so particular superiority using DCB comparing DES, but actually a little bit favor of the DCB. I think one more recipe need in this era. This is a combination shot. Actually, this is a Japanese guy using a laser and then additional high pressure and then a DCB. And finally, panel G shows a very beautiful open up actually 8 months later. So finally, this is my summary. Medina 0.0.1 bifurcation shows a high rate of the adverse event. Imaging guidance bifurcation stenting in the clinical outcome except 0.0.1. Even with the aid of the imaging guidance, stenting 0.0.1 have a higher risk of the Mason TLR. To improve outcome, better to get the best preparation, imaging device and the selection of appropriate device is very important. But you need a Hawkeye and need a great skill. The nailing 0.0.1 with or without finishing DCB actually is your choice. However, it wasn't as good as we thought it would be.
Hello, my friend. This is Einstein speaking.
This is
If
AI
you want to place a stent
voice.
at the entrance of the circumflex branch, you may do so. But if you wish to finish with a DCB, that's fine too.
He doesn't have a...
Hello, my friend.
Okay.
This is Einstein speaking.
He doesn't have a responsibility. Okay.
Thank you very much for the excellent overview. Do we have some comments? Are there questions from the audience?
Maybe I think you always discuss about how to, decide the size of the DCB, how to use the imaging, something like this kind of question. Maybe I think Professor Shin can answer. Maybe I think this is also the very important point. But actually, DCB itself, maybe we need a best preparation first, and then the appropriate size of the DCB. Please.
Thank you very much. So, beautiful lecture. And yes, and bifurcation 0.0.1 is very, very difficult. Recently, we also analyzed the DCB registry with the COVID-3 registry for analyzing the bifurcation 0.0.1. And, but there is a quite a different result from the Antonio Colombo data. So our data is DCB, only treatment is have a better outcome. Target lesion value is very low in the DCB treatment arm compared to the stent arm. So, and I usually use the I want to do my best to make the good lesion preparation. So, and on circumflex ostium is very difficult to make the optimal lesion preparation. So I usually choose the optimal size by angiography, the scoring balloon first, and then I just slightly upsizing the non-compliant balloon with a high pressure application for the ostial lesion. So after that, I just choose the final device according to the result of the lesion preparation. So the lesion preparation is good. I mean the good flow, and residual dimer stenosis is less than 30%. That's okay. So I just apply the DCB alone treatment.
Okay. So from my understanding, actually, in a case of DCB in a 001 lesion, maybe we need a dissection of the circumference part. And if we can identify the dissection, and if the dissection is not so big, maybe we can use DCB. This is just my idea.
Thank you. So now, lesion preparation will be analyzed in the next presentation. So we can move for the intravascular lithotripsy IVL by José Montero-Cabezas.
Thank you very much for the invitation. My name is José Montero from Leiden University, here close by. So welcome to the Netherlands. So this presentation, this slide has already been shown that we know that 001 lesions are really scarce, that we don't find it every day, fortunately, for us and for the patient. But the presence of calcification is even more rare. And we see here in this collected data of the 3 major registries that we see that in the group treated with one stent, calcification, severe calcification defined exclusively on the fluoroscopic appearance was present in 11%, and the 2 stent groups, it was in 24%. So it's even more rare to find this on a regular, in a clinical practice, right? The thing is, most of the studies are focused on the presence of severe calcification, mostly based on fluoroscopy, right? And we know that fluoroscopy is absolutely insufficient to define the calcification phenotype of the lesion we are treating. And we know now, after all this, in the past years, have more information about the role that eccentric calcification, deep calcification, superficial calcification, nodal calcification may even have in the outcomes of the PCI that we are planning to perform, right? We don't know what kind of calcification phenotype these patients, specifically the Medina 0.0.1 lesions, have, and the technique selection and the outcomes may differ absolutely from one technique to another one based on the phenotype that we are confronting. Here that we have the data, for example, just focusing on calcium nodules, we know that it's not the same dealing with an eruptive calcium nodule than a non-eruptive calcium nodules in terms of MACE. So phenotype matters, and we have to do a better job in phenotyping the pattern of calcification that we encounter in these challenging scenarios. We talk about intravascular lithotripsy, and we have currently two, there are others, of course, but these are the systems that are now prevalently used in the world. One is Shockwave with extensive experience already, a bunch of information and data already available in different scenarios. It's based on a system of acoustic pressure waves generated by emitters mounted on a balloon system who's able to generate these sonic pulses which are transmitted through the vessel wall and are able to selectively target the calcification and generate cracks within the calcium, right? These cracks are produced even on the superficial aspect of the calcification, but also in deeper layers of the calcification, allowing the balloon to expand progressively with the administration of subsequent pulses. We have the LithiX system as well, which is also an intravascular lithotripsy system, which is based on a completely different mechanism. It's based on the Hertz contact stretch principle. The balloon we have spheres mounted on the balloon system. It doesn't require an external energy source, and by applying pressure on the balloon, the forces are really focused on these spheres, so are able to crack the calcium, right? So generalizing the effect of one technology to the other technology is still debatable, right? So the data that we have now is mostly based on the Shockwave system, so we need more evidence to really conclude that both systems are equally effective. So why is Shockwave, or in this case IVL, useful in 001 lesions? Has been briefly mentioned already. We're talking a balloon-based, operator-friendly, all-road device. So this is something that you can, it's a philosophy. If you can cross it, you can crack it, right? So IVL has been proven to be effective in all different morphologies and phenotypes of calcification. We are able to generate circumferential calcium fractures with low barotrauma. For those who are using this technology on a regular basis, only by inflating a balloon to 4-6 atmospheres is just enough to deliver the pulses who are fracturing the calcification. The balloon profile allows delivery in many side branches where atherectomy devices are challenging, for example, angulation, and where we know that, for example, when dealing with a calcified ostium, ostial CX, we can generate easily perforation when the calcification is really marked. We can generate effective compliance gain at the ostium, and the effectivity, as I said, is being proven in all different scenarios. Even here we have why Shockwave, even confronting eccentric calcification and even nodal calcification, is able to generate at a low pressure fractures on the calcification that we are facing. So compared to other devices, just this balloon-based therapy, atherectomy or IVL, we can see what the potential advantages on a theoretical level are of IVL. We're not depending on the hydrostatic forces, selectively targets calcium and not the soft tissue surrounding the calcification, is able to modify both superficial and deep calcium, is independent of wire bias, an issue that we are confronting on a regular basis when we are using atherectomy devices, and is independent of lumen size as well, right? So the effect on IVL in the different calcium morphologies has been already shown in several studies. This is one study from Madrid, Professor Scanet, where IVL was analyzed both in eccentric and concentric lesion patterns assessed by OCT, and they could show that the effectiveness of IVL was not significantly affected by calcium morphology at all. So it works also in eccentric anatomies, which is also something that we find regularly in bifurcation lesions. So there are some concerns about the profile of these balloons. Being accused of being bulky devices, were unable to cross really challenging anatomies, calcification and angulation, like in 0.0.1 bifurcation. So we know when we are performing imaging, calcification not only affects the ostium of the side branch, like in this case, that we often have, although not visible on fluoroscopy, calcification in other locations within the bifurcation that we are treating. Even though we might not be able to cross initially the side branch, using Shockwave on IVL, in the main branch, we are able to generate field effect, and we are able to generate cracks in the side branch that we're intending to treat. This is a figure from a, Can I go back here? So we have a figure here of the lesion, which is, of course, not a 0.0.1 lesion, but we are treating this main branch here. We have the side branch here with an IVUS, and after applying lithotripsy in the main branch, we're able to observe cracks in the eccentric calcification that we have in the side branch. So by applying this field effect concept, we are able to prepare the lesion, even though we don't have the balloon inflated at the target lesion itself. So we might solve uncrossability, and there's more thing coming in the market. So the company Shockwave has developed this new device. It's called Javelin, which is a forward intravascular lithotripsy platform with a single distal emitter mounted on a catheter, which is 1.5 millimeter crossing profile. So we are able to deliver anterogradially with just one emitter the energy that we require to break the calcium and allow our catheter to pass. So we have been using a balloon base. It has been told that you need to inflate the balloon properly, and you need to have proper contact with the vessel wall, but actually only with one emitter, even though the vessel wall is not probably in good contact with the catheter, we only lose 10% of the energy. So we are able not only to provide the pulse waves anterogradally, but we are able simultaneously to treat the deep calcification as well. And the company says that the need of using even a larger IVL balloon afterwards is less than 10%. So we will see as soon as the device arrives in the market that we are able to put our hands on it. So what is the evidence on IVL in 0.0.1 lesions? It's very, very limited. This is the only paper published to date. It's coming from our group. It's from the Benelux IVL registry, which at this moment comprises more than 800 patients. The analysis was performed when the registry included 500 patients. Bifurcations lesions were present in calcification treated with IVL, only 114 lesions, and of those, the Medina 0.0.1 lesions were only 7. So we have very, very, very scarce information regarding this specific subset. We could see that in general, in the study, we proved that the IVL crossing success was almost 100%. So these lesions also were able to be crossed with the device. The technical success and the procedural success were also quite high, and compared to the non-bifurcation lesions treated with IVL also from the registry. So we need more data, and we need to, to define a little bit better what we're doing and how are we tackling these lesions. So as a conclusion, calcific 0.0.1 lesions are infrequent, but are absolutely a challenge from operators. Identification of a phenotype of calcifications is absolutely critical to define the best approach. Otherwise, we don't know what we're doing. IVL, I truly believe this is a balloon-based, operator-friendly technique, growing evidence across all calcification subtypes, which may simplify the procedure, and current evidence is, of course, very limited, and the limitations that we have, like uncrossability, might be solved in the future. So one device to rule them all, we will see, but IVL may become the way to go strategy for calcific ostial bifurcation disease. Thank you very much.
Thank you, Jose. We have no time, so we decide to make a common discussion in plaque preparation with the other. Please remain over here in order to respond to the question. Peter? Peter is in charge of analyze the rotational and orbital atherectomy in the preparation of the plaque in 0.0.1 bifurcation lesion.
Thanks, Manuel. I feel very tall on this step. I'm not as tall as this normally. So thank you very much. It's great to be here. And this talk is going to be a little bit technical as well. I think we've heard some great talks so far. And I'm just going to press play. So my remit is to talk about the two atherectomy devices. Of course, there's a third atherectomy device, laser. Briefly mention it in here as well. And my conflicts of interest, and one of the main ones is I live in Bournemouth in the UK, and it's got lots of calcium, so I feel like I see a lot more. Now, 0.0.1 is clearly a lesion that's complex, and it comes back, so we've got to make sure we should treat it in the first place. And if we're going to treat it, then I think what we've seen earlier on today is how CT coronary angiography is such a great tool at recognizing the presence or absence of calcium. And I think it's available, and this, we don't need fancy packages. We just need to sit down on our consoles and look at some of the images, because they're all there for us. And I think it gives us a huge amount of information before we go anywhere near the case. We can work out whether it's focal disease, whether it's vessel specific. We can understand the morphology in more detail, and that will allow us to plan our strategy in terms of what tools we might need, and also perhaps what operators we pick. Because I think in a world where some of the cases may be becoming more complex, but some of the newer doctors have less access, we need to be able to train. And that's from Carlos's P4, we get some incredible information. But then when we get into the cath lab, we need all the information we got, and we need all the tools. And as well as atherectomy, we need cutting balloons, we need dual lumen catheters, we need enhanced X-ray. We need to understand, but imaging for me is clearly super important. We've heard it already. The angiogram doesn't give us the answer. There's various scoring systems that have been updated now, the rule of threes now for OCT. The scoring system with IVUS is very good. And I think applying these in your practice actually can make a difference. And it probably makes us better at selecting which cases we will need which tools for. So that's a kind of overview. But why is it this particular circumflex ostial lesion that's so complex? Well, we know from the pathologies that the flow divider is spared, and the material kind of comes on the sides of the lesion, and in the left main, it may even encroach a little bit onto the flow divider on both sides and further down. And as we get more and more plaque there, and it's more fibrotic and calcific, it's harder to deal with. And we've already heard how all the stent options or balloon options are imperfect, but understanding what we're planning to do and what we're capable of doing is worth understanding at the beginning of the case, because that may influence how we prepare the vessel, because lesion preparation is going to be key. In this example, this wasn't really suitable for atherectomy. It's tortuous, there's high risk of damage and perforation. So safety here, as we heard from Jose, IVL works for all types of morphology. It's much easier to apply it in this situation. So rotational atherectomy then. It's been around for 30 years. You know, we're using it still a lot in our practice. It is very safe, but we have to recognize that there are complications, and I'll go through some of those potential hazards a bit later. But it does work. It works very effectively, and we shouldn't shy away from it. We need to maintain our skills, and we need to keep teaching people how to use it, because, you know, obviously with other technologies like IVL, this technology is threatened, and we need to keep practicing it because there is a learning curve. Now, the new Rota Pro system, which I'm sure everyone in the room is using, I think is a big advance from the old system. It's less clumsy, it's easier to teach. And things like the console are much simpler to see. You can understand where you've got decelerations, and it can make you a more expert operator in terms of how you actually apply the rotor burr to the lesion. I like to keep my runs very short, but every case you have will be slightly different in terms of how you might apply this technology. One thing we have is a wall inlet that makes it much easier than a cylinder. So there are a number of complications. There is clearly a learning curve, but it is super effective. And historically, we used to often use two burrs, maybe in 10, 15, 20% of cases. We don't do that now. We kind of use combination therapy, and perhaps that's also the answer. But things like angulation and the circumflex angle can be, you know, quite extreme, and I think that makes the cases a bit tougher and perhaps more liable for problems. We need to be conscious about the guide cath. Often the guide cath will sub-select the LAD, but when we're trying to treat the circumflex, we need to make good engagement and make sure it's angled towards the circumflex to really get good backup and allow our burr to run around the corner very nicely. And of course, wire bias is a complex subject in some ways. You've got a choice of wire with rotor. You can use a more stiffer wire, or you can use a floppy wire. And it will also influence where the plaque is. If it's just at the ostium, it probably doesn't make too much difference. But if you've got plaque further down the vessel that is incorporated into this lesion that you have to treat, then the wire will make a difference, because the wire bias will be different according to which wire you might use. So it's worth paying attention to that. And of course, I think the similar thing with orbital, when we talk about that, the wire bias will also affect how this device works. And imaging, I think, is another way of understanding where the wire actually is in relation to the lesion, and that helps us to select our tools better than perhaps we'll ever predict on an angiogram. So just be mindful of that. Now, obviously, differential cutting is how rotor works, and if it does work, it works perfectly well, and you clear out some of the tissue. But of course, there is the risk that it will go to the, particularly angulation, it will go to the other side of the vessel, and that's obviously a bad outcome. And perforation is clearly a risk for rotor, it's a risk for orbital, and I would say roughly around 2% from the literature is, you know, it's not insignificant. So I'll just show a few cases where different techniques. This is an 80-year-old retired cardiologist, father of an interventional cardiologist, who bit of pressure there, and has 8 segments ischemia in the circumflex territory, having had bypass surgery with an occluded vein graft, so a patent lemur to the LAD, and actually couldn't get anything to cross that lesion. My plan was to try and debulk the left main and then get into the circumflex, because it was tried before people couldn't wire it de novo. So in fact, this was a case where we had to really use all the tools in the box, had to pull out laser initially to get through that initial tough, tight stenosis, and then a 2-burr strategy. And the idea here is that we're spending some time just to get rid of as much material, so more debulking and crossing, to allow us access into the circumflex. So once we've achieved that, then I'm in a position where I can use a dual lumen catheter with a bit of backup and then get a wire into the circumflex. Interestingly, then I switched out with calcium, switched out for a rotor, and you can see here it's quite interesting because the wire flips back as the burr goes around the corner, and it happens a couple of times. I still don't really understand that. I think it was a bit of tension in the system. Anyway, we had to use IVL because I felt that was going to be a safer option. But we got a good result in this, and you'll be pleased to know 3 or 4 years down the line, the patient is very well and angina has sorted. So that's one case. The second case is another example, and this one is a revived case. So all of you who know the literature have read revived, you either believe it or you don't. This ejection fraction was about 10, 15%. We did the LAD first, a stage without any hemodynamic support. And the challenges here was obviously the burden of calcium. And the technique was a little bit different here. So using just a single burr and going cautiously and slowly with short runs to avoid debris and to avoid no reflow, and obviously to avoid hemodynamic compromise. And these cases, obviously some people will say you must always do them with an impeller. We've just finished randomization of the impeller trial. That'll be reported at ACC, so we'll find this out. A different study, CHIP BSIS 3. But in this case, I didn't use a support device, and actually just being very careful with the burr. And then once we've achieved our sufficient rotational atherectomy, then use balloon technologies just to make sure we've got expansion, maybe a cutting balloon as well, a bit of scoring just to get really good penetration of that plaque to the sides. And we ended up finishing off with a stent back to the left main and some DCB work in the two marginals, and everything stayed open. That was good. So moving on then to orbital, again, we have the similar type of scenario. We have to think about both the safety concerns and also the efficacy. And we've seen already that there's always a feeling that this device may be superior for these ostial lesions because we can actually penetrate this more eccentric plaque. So you may not be as familiar, so I've given you a little bit more in terms of the setup. So the Viper wire, highly deliverable. The console is fully electric, so there's no air inlet. The console is very, very basic, but it does its job. There's no knowing how fast it's going. You just set the speed at either 80 or 120. We don't get that recorded. The crown, as you'll be familiar with, is bidirectional. Viper fluid, you've got to check that they haven't got allergies to egg. And then the console itself is very simple. It's got some safety cutouts. If the brake's on or off, it doesn't work. We've got the glide assist button, and then we've got the controller knob, and it's very, very simple to use. It's a two-person technique to deliver. It's probably the easiest way to do it. You haven't got a one-person option here, but it's really simple to deliver to the coronary. Obviously, the brake's on, and once you're in there, this is me and Helen doing a case a number of years ago. It is a very calm place to be. It's very simple, and I actually really like it because I don't find the patient has too much hemodynamic compromise. You've got to keep the crown moving ever so frequently with a little bit of oscillation. And I like to glide assist across the lesion. And we know from the imaging studies and data that's been published, it creates this kind of fractures, but also kind of carves out a little concave area. And you do get a little bit of malapposition in about 7% of the cases. So I'll give it just a few examples. So this was quite a tricky circumflex to cross. Initially, balloons didn't really cross it. And so here we actually can glide assist, and sometimes there's resistance to the glide assist, but it is quite good. It's like having a very aggressive microcatheter, and you can get it through the lesion. And I think it's safer to go through on glide assist and then do the most of the work as you pull back in the retrograde fashion. I just think that probably reduces the risk of perforation, but also it might make it more effective because you're actually targeting that more eccentric plaque. And it will work both at shaving and also perhaps more deeper at trying to crack those deeper plates of calcium. So it could be a device that suits everything without needs to combine. That's the OCT. It's not the best run. You see there's a bit of swirl. And there are some fractures there, and we see a little bit of the concave effect, but it's certainly very disrupted. And actually, patient tolerates these very well, I find, and actually very effective here. We finish with stent in the circumflex, and then we DCB the LAD, as we've heard, the hybrid approach. I think that's the best for this type of scenario. You don't want to put two stents in with that burden of calcium. Here's another case. This was obviously it's had bypass grafting before. It's got patent lemur, but it came in acutely. It's got a big circumflex system with a very tight calcific stenosis. And this one, we had to do a little balloon just to get the OCT catheter down. But I think it's a good example of where the OCT catheter is sitting next to the calcium. So I think you could use either technique here. But actually, orbital works really effectively. And again, glide assist through 3 runs at low speed, 5 runs at the high speed. Don't often have to use the high speed, but in such a big vessel, I think it's both safe and probably will give a bit more efficacy. And of course, once we've done that, we're then in a position where we can start to use some balloons just to make sure we've got good expansion. And then, of course, repeat the OCT, which I think is key in all these cases, systematic imaging throughout so that we don't miss whether we've prepared things or not. And you can see on OCT, it's pretty clear. We've got good luminal gain. We've got some disruption, maybe some fractures there. And I think we're all good to go. and put a stent in, and we put a synergy stent pot with a 5.0. In fact, I haven't shown you, but there's another OCT run where there's an edge dissection distally and have to cover that. Quite a nice OCC with a bit of hematoma, but a second stent looks good. And in this case, I think it's a really nice example. Sophia showed it yesterday in one of the sessions. But it's a great case of a proper 0.0.1. You can see the calcific plaque on the OCT, and it's probably a sort of mixture of morphologies, definitely a nodule there, and a degree of eccentricity. Now, we always kind of try and do this sort of MLD approach to get all the measurements, and then we go with a balloon strategy, and based on really the safety profiles, a woman, there's good evidence that it works, IVL, but in fact, after delivering all the pulses, the balloons don't expand. And then the OCT, again, really confirms the presence of more, perhaps, nodular calcium, and you can see that the wire bias really is such that I think Rota will probably not work here. We're a 6 French system, so 175 is not going to have a big impact. So for me, this is an orbital case because I think it's going to be much more effective. And rather than just sort of, putting a stent in at this point, we take the orbital down, and after we've done some orbital, we get a really good result with ballooning. Then we're in the bifurcation. We can just, again, stent circumflex back to left main, do a nice pot, do a recross kiss, and then whether we need to or not, but it feels better to finish with DCB in the side, and then a final pot just to get a nice overall result. You can see the burden of calcium there is quite high. And actually get very good results with this type of treatment, and you get nice MSA. So final slide. So you're wondering what this is. This is obviously Eclipse. Now, Eclipse kind of almost killed orbital technology, but it was the wrong study because they were comparing it in cases where balloon treatment was possible. Now, we've put together a 300-patient registry called the Ball Registry, and this is we just got our first patients into this last week. It's only in the UK, but it will allow us to try and understand a bit more mechanistic understanding. All patients are included. There's very few exclusions, and it's all going to be properly systematic OCT guided. So we're going to understand the pre, the peri, and then the post. So hopefully, in a couple of years, we'll be able to come back and hopefully we'll have some 0.0.1 lesions to tell you about. Thank you very much.
Unfortunately, we have no time for discussion. I will ask only a single and quick question to both presenters regarding the plaque preparation. The incidence of LAD compromise after using rotational atherectomy and after using IVL, you know about the percentage?
I think it's pretty small. I think the literature would, in personal experience, it's very, very low, the risk of damaging either side branch or main vessel when you rotablate. You can do what Niccolò was telling us yesterday. You can use a guide extension perhaps as protected if you're really, really concerned about those.
Jose?
So I think it's important to have in mind what is going to be plan B in case that occurs, more than the chances of that it will occur, right? So if you have presence of pre-existing calcification, you have to work a lot on the vessel before. The chances are larger. We're inflating the balloon up to 6 atmospheres, right? So we're not expending a lot of shifting of something. It's quite safe if you take the right steps and prepare for what's going to happen.
Thank you very much. And now I'll introduce Manuel Pan, my co-chairman, to finalize the session. Manuel.
I'm going to be fast in order to summarize this interesting session. So the first concept is that the circumflex ostium is a real problem. May I have the slide, please? It's a real problem. And what can I do in this situation? May I have the slide, please? Well, if not, I can summarize, so don't worry. I think we have to follow 3 single steps. First, to do image. Second, the plaque preparation. Third, decide the strategy with or without a stent. For me, is the most difficult step in the treatment of the ostial circumflex. And fourth is the use of image again in order to optimize the procedure. So I think that in the step 1, 2 and 4, we have an agreement, and for the selection of the strategy, we have not data, we have not evidence, and I think that we need an EBC consensus for the next year. So now we announced that we will work in this consensus regarding the percutaneous treatment of the circumflex ostium lesion. So thank you for your attention. Thank you for your participation. Thank you to the panel, to the audience, and continuing having an excellent meeting.